Hi, this is Dr. Marty Lofka. I'm the Internal Medicine Clerkship Director at SIU School of Medicine, and this is part two of a three-part workshop on basic electrocardiography. As a reminder, part one included a lot of preliminary basic information about EKGs, including limb leads versus precordial leads, the placement of those leads on the patient, and the layout of those leads on a 12-lead EKG. It also included normal intervals, as well as a discussion of how to determine rate. In this part two, we're going to talk about rhythm analysis. Rhythm analysis is typically the most difficult portion of interpreting a 12-lead EKG. And so we're going to spend a significant amount of time talking about rhythm analysis in this session. So the first thing I would do if I were handed an EKG and trying to determine rhythm is to ask two big questions at a first glance. One, is the rhythm regular or irregular? And if it's irregular, is it irregularly irregular or regularly irregular? If the rhythm's irregularly irregular or regularly irregular, I'll have a couple of different ideas of what could potentially be causing that abnormality in rhythm. And so that may point me in the direction of a particular diagnosis. The second question that I would ask is the QRS complex normal or prolonged? That means the QRS interval, which is normally less than 120 milliseconds or 3 small boxes on the EKG. If it's prolonged, that could signify either a conduction delay, meaning a right bundle branch block or a left bundle branch block or some other non-specific intraventricular conduction delay, versus a ventricular rhythm. So after asking those two big questions at first and tucking that information away to help me with my analysis of rhythm, the next step is to look and see what's happening in the atrium. Remember that the P wave is the atrial depolarization, and I want to know if I can find discrete P waves on my EKG, and if I can see discrete P waves, whether or not they're coming from the sinus node versus an ectopic area of the atrium. So I'm going to take a look at the rate of P waves throughout the EKG. Is that rate normal, 60 to 100 beats a minute? Is the rhythm regular? Is the P wave flat or upright in lead 2 and down in AVR? And does the P wave have the same morphology with every beat? Because if you have an ectopic atrial node, then you could potentially have different morphologies of P waves in the same EKG. Additionally, I'm going to then take a look and see whether or not there is a P before every QRS and a QRS after every P. And the other thing I want to take a look at is whether or not there are any unexpected early QRSs or unexpected pauses, because maybe I have a sinus rhythm, but I also have some premature complexes like a premature atrial complex, premature ventricular complex, premature junctional complex. You can also see sinus arrest or sinus exit block, AV nodal blocks, and non-conducted PACs that can also cause unexpected early QRSs or unexpected pauses in an EKG. So let's take a look at this EKG as an example. We've seen this EKG previously when we were attempting to determine rate in part one. And so I've been handed this EKG and I'm taking a look and I'm saying my two big questions at first. Is the rhythm regular? Yes, it is. So if I go through and look at my QRS complexes with the R to R intervals all the way across, they appear to be the same. My rhythm is regular. And then my next question is the QRS interval prolonged or is it normal? And so I'm going to take a look at the QRS complexes and really try and find one where it is the widest in appearance. And so at first glance, I'm going to say the QRS complex in lead V2 appears to be the largest. And so I'm going to measure the QRS complex interval here, which is clearly less than 3 small boxes. So it is normal. So that is less than 120 milliseconds. So I have a normal QRS interval. So for this one, okay, it looks like I have a regular rhythm. I have a normal QRS complex. My next step is atrial analysis. So what are the atria doing? Can I find P waves? So I'm looking for P waves. And so I'm going to take a look at the rhythm strip at the bottom because there are clearly definable P waves throughout the entire rhythm strip. So this is in lead 2. Remember, if I'm looking for sinus nodal activity, is it regular? So here's my P wave. I'm going to come down here, P wave, P wave, P wave. And you can count those out or march those out throughout the remainder of the EKG. So I do have discrete P waves, and their rhythm does appear to be regular. And the P waves are upright. This is in lead 2. So the P waves are upright in lead 2. And so do I have a P for every QRS complex and a QRS for every P? Yes, I do. There are no unexpected pauses or drop beats. So I can confidently say that this is a sinus rhythm. This rate for this EKG we had determined previously to be about 54. So the rhythm in this EKG is in fact sinus bradycardia. So we know that the rhythm is coming from the sinus node, and we know that the heart rate is a little slow, so this is sinus bradycardia. So let's take a look at some other EKGs or telemetry strips and try and figure out what may potentially have happened. So when we take a look at this one, what potentially happened here? Well, we can see that there is clearly a PQRS-T, PQRS-T, and then we have this area that is has a dropped beat, and then we're followed up with PQRS-T, and then back into a regular rhythm after that. So we have our R to R intervals before the pause, and the R to R intervals after the pause are the same. We have a P for every QRS and a QRS for every P in this situation. And we clearly have P waves that are the same morphology, except perhaps a little bit of a strange morphology on that one. But for the most part, they're all the same morphology throughout and are regular except for this big pause. Of note during this pause, there is no P wave before this dropped QRS. So there's no P wave, no QRS, and no T. So in this situation, what we have is either a sinus pause or a sinus exit block, meaning that the sinus node has fired, but there's a block immediately after the sinus node such that the atria do not depolarize. So remember, sinus rate is constant. It's rather constant. And so therefore, when there is a pause, then the next P wave is a multiple from the previous P wave. And so if we were to measure this R to R interval, it's going to be 2 or 3 times the distance. It looks like by eyeballing it, it's 3 times the distance of the other R to R intervals. And so this was either a sinus exit block or a sinus pause. So what do we see here? Well, we see a couple of abnormalities actually. So we have a QRS wave here and a T wave here. Here is a P QRS T, and then all of a sudden we've got a QRS, and there's a missing P here, and then T, then P QRS T, P QRS T. and then a significantly different QRS complex with an inverted T wave, and then P, QRS, T, significantly different QRS complex with an inverted T wave. And of note, for both of these, there is a missing P wave as well, and then back into a P, QRS, T. So for these two larger QRS complexes that have the inverted T wave are typical of premature ventricular complexes. So that makes sense why there's no P wave here. We have a very different QRS complex that is wider than the normal QRS complexes, and has an inverted T wave. So those are premature ventricular complexes. This one that is also missing a P wave, it also has a slightly larger QRS complex in amplitude than the normal ones here. So, this could potentially be a premature junctional complex because there's no P wave before it, so it could be a premature complex arising from the bundle of His or somewhere around the AV node. Could also be something called a fusion beat, where there could very well have been a PVC that was starting at the same time that there was some depolarization happening within the atria, and so you get a fusion beat. So it could have been either of those. For the PVCs, if you have 3 or more PVCs in a row, that is VTAC. And if you have 30 PVCs in a row, you get sustained VTAC. Okay. Let's take a look at this one. So this one we can see right off the bat, we've got a fairly regular rhythm, except in this area that I am marking here between these two QRS complexes. So I've got a PQRST, PQRST, and then a premature P here with a QRS complex and T wave, and then a pause, and then PQRST. And so in this situation, I definitely have a premature P wave leading to a premature complex. So this is a PAC. So premature atrial complexes, you'll see that premature QRS complex that's preceded by a P wave, and then you'll have this compensatory pause immediately afterwards. Let's now take a look at this full 12-lead EKG with an included rhythm strip and try to figure out what's happening with the rhythm in this situation. So at a first big glance, I can see that my rhythm is irregular. We've seen this EKG before in part 1. We determined the rate at that time to be about 54 beats per minute, so a little bit slow. And we've also identified that this EKG has a rhythm that is regularly irregular, meaning that it has a pattern to it. So now we need to figure out why this rhythm is regularly irregular and what's happening. So I've asked that first big question. I've got a regularly irregular rhythm, and I'm taking a look at my QRS complexes and trying to find the lead in which they seem to be the biggest and easiest to measure. And so I'm looking at V3. I think that makes it fairly easy to measure. And so there is the beginning of the QRS complex. Here is the end of the QRS complex. And it's right at about 120 milliseconds. So not really prolonged, still within the normal QRS interval. Okay, so I don't think I have a conduction delay, and I don't think I have a ventricular rhythm. So now I need to find what's happening in my atrium. So now I'm going to start taking a look and trying to find P waves. And so I'm going to use the rhythm strip at the bottom. And so this is lead V1. And if you look closely, the P waves in lead V1 are bimodal. They have both a portion that's above the baseline as well as below the baseline. So here is a P wave right here. Okay. And then I look across and I'm like, here's my QRS complex and a T. And then all the way over here, here's another P wave. I'm going to mark that. And then my QRS complex and T, and here's another P wave right here. QRS complex and T, and here's a P wave, and P wave, and P wave, and P wave. So once I've marched those out, what I'm noticing is that I have a rhythm that's also regularly irregular. Well, that doesn't make sense for P waves because remember the sinus node is regular. Unless someone has sick sinus syndrome, which is not a particularly common situation, that those P waves should be coming in regularly. And so then I need to try and figure out where's that missing P wave. And so I will measure my P to P interval here. And if I march that out to the next matching P to P interval, that is happening right in that T wave. If I look at the T wave actually looks like it has an extra little hump. It looks different than this T wave over here. Okay, so then I bet I have a P wave buried in that T, and I have a P wave buried in this T, and a P wave buried in this T and this T. Okay. So I therefore don't have a QRS complex for every P wave. And then the other thing I'm going in through here to see is like, well, my PR intervals are changing. So I've got a fairly prolonged PR interval. Remember, your PR intervals normal is less than 5 small boxes or 200 milliseconds. So it should be between 120 and 200 milliseconds, which is 3 small boxes to 5 small boxes. So I've got a very prolonged PR interval here. I've got a P buried in this T, and so dropped QRS. And then this PR interval, it's still prolonged, but it's not nearly as prolonged as that first one. Then my next PR interval is lengthening, and then I have a drop beat. So this is Wenckebach, so Mobitz type 1, second degree AV nodal block, also known as Wenckebach. So I have a sinus rhythm, but I also have an AV nodal block in this situation. Okay, I hope that example EKG made sense for you. So if the atrial analysis shows that my rhythm is not sinus, then what is it? So if my atrial rhythm is not sinus and the atrial activity is still organized, you would want to consider atrial flutter versus an SVT. If the atrial activity is chaotic, you would think about atrial fibrillation. And then there's also this entity called multifocal atrial tachycardia, where you do see discrete P waves, but you see multiple morphologies of P waves such that it shows up as a irregular rhythm, but not consistent with atrial fibrillation, where you can't really see discrete P waves, but rather you get a noisy baseline. If you can't find any atrial activity at all, but you still have a narrow QRS, then you would consider the potential that you could have a junctional rhythm, especially if the heart rate is running between 40 and 60 beats per minute. You may also have atrial flutter with 2-to-1 conduction if you've got a very fast heart rate, as well as PSVT and atrial fibrillation. If you have a widened QRS, then you have to consider whether or not you have a concurrent conduction delay, meaning a bundle branch block, or a nonspecific interventricular delay versus a ventricular rhythm. Let's take a look at this EKG as another example. So at first glance, my rhythm appears irregularly irregular. It's kind of tough to tell because the technician has decided to use lead V1 as the rhythm strip, and you can see that the voltage in lead V1 is very, very small, and so it makes it difficult to determine which are the QRS complexes in lead V1 versus P waves. But if I were to look in the other precordial leads, it's quite a bit easier to see the QRS complexes. And lead 2, there's fairly easy to identify the QRS complexes as well. So my rhythm does look irregularly irregular. And then if I take a look at the QRS complexes, they appear to be normal. They're not prolonged. And so I know I've got most likely an atrial rhythm of some type happening, um, but I don't know what that atrial activity is yet. So now I'm going to start looking for discrete P waves. Can I find discrete P waves? And again, lead V1, it's kind of tough to see. I can see P waves, but they're not as easy to see as in the precordial leads, particularly lead V3, and I think 4 and 5, I can see P waves more easily. So if I'm looking at lead V3, here's a P wave here. I can't really see a discrete P wave here, but here's a P wave, and this looks like it might be a P wave. Again, can't really, it may be, the P wave may be in conjunction with a T wave here. Here's a P wave, here's a P wave. I think I could talk myself into P wave here, and especially if I move up to lead V5. Again, may have been buried here in the T wave, but that's a definite discrete P wave, and this is a discrete P wave as well. The thing that I'm noticing about the P waves is that they have different morphologies. Not only are they occurring with a different PR interval occasionally, but they do have different morphologies. And so this looks like a multifocal atrial tachycardia to me. So you have to have at least 3 different morphologies of P waves in order to call something MAT. But that would be my assessment for the rhythm on this EKG. So if I can't find any atrial activity at all, so I don't think I can find any bouncy baseline that would go along with atrial fibrillation. I can't find any discrete P waves. Then I would next move on to a ventricular analysis. I would only do this analysis in the situation where I cannot find any atrial activity. So if you can't find atrial activity, but you do have a regular rhythm, if the QRS complexes are narrow, meaning the interval is normal, if the rate is running about 40 to 60 beats per minute, you probably have a junctional escape rhythm. If the rate is running 70 to 130 beats per minute, you probably have an accelerated junctional rhythm. And then if the rate is greater than 140, you would call it a PSVT. Remember, PSVT is essentially a catch-all term for a supraventricular tachycardia. It's not, we're not talking about criteria and trying to determine which type of PSVT that is happening here, but just, know that if the rate is greater than 140, it's probably a PSVT. If you have a widened or prolonged QRS complex and the rate is running at 20 to 40 beats per minute, you likely have a ventricular escape rhythm. If the rate is 55 to 110 beats per minute, you have an accelerated idioventricular rhythm. And if the rate is greater than 140 beats per minute, that's VTAC. So here's another example EKG. And on this one, notice there is no rhythm strip. We just have the 12 leads represented on this EKG. So if I'm taking a look, my two big questions at a first glance in terms of rhythm, is my rhythm regular? Yes, if I were to measure and march out the R to R intervals between each QRS complex, they would be the same. So this is a regular rhythm. And then my next question, is the QRS complex prolonged or is it normal? So I'm going to go and try and find a QRS complex that appears the widest that I'm going to be able to see. And I would say maybe lead 2. And so if I were to mark the beginning of my QRS complex here, and my J point is about right here. And so this is bigger than 3 small boxes. It's almost 5 small boxes. So this is a prolonged QRS complex. All right. And then next would be my atrial analysis. Can I find any discrete P waves? And I'm going to look in every single lead. And remember, my 10 seconds in time runs all the way across here. And so even though it's switching between leads, that's still running consecutively 10 seconds in time. And as I look in each of these leads and trying to find a discrete P wave before my QRS complexes, I cannot find any clear P wave or atrial activity. So in this situation, I would then go to my ventricular analysis. And so I have a regular rhythm that with a prolonged QRS complex with no discrete P waves. And if I were to measure my rate's probably running about 150 beats a minute. So that's greater than 140. So this is likely BTAC. Now, the one thing that I will point out is that there are P waves, but they are retrograde. So if you notice, here's a T wave going directly into our QRS complex, and then there is this little hump on the back of the QRS complex. You can really see it in lead V2. These are retrograde atrial depolarization deflections. Okay, I hope that the rhythm analysis steps made sense to you. What we're going to do now is apply those rhythm analysis steps to some common arrhythmias. You may very well recognize the arrhythmias just from pattern recognition in your previous study, but we're going to show how we can apply that rhythm analysis to these common arrhythmias, because some EKGs are not as straightforward as the classic examples that you're going to see. Okay, so if we were presented with this EKG, really it's a single lead, and we were asked to determine the rate and rhythm, let's try and figure out what's going on based on what we've learned so far. So in terms of rate, one thing I know for sure is I can see that my rhythm is regular, so I can use the rule of 300 to determine rate. And so I'm going to find a QRS complex that's going to be the closest to the bold hash mark. And so I'm taking a look at this one. And so using the rule of 300, 300, 150, 100, 75, 60, 50, 43. So we've got a significantly slow heart rate. And so I would say this is around 40 beats per minute. All right. So I already know I have bradycardia. Now I need to figure out what type of bradycardia. All right. So we're going to do rhythm analysis. Do I have a regular rhythm versus irregular rhythm? We already know it's regular. And if I'm looking at the QRS complexes, they're clearly of normal interval, so less than 3 small boxes. Do I have a P before every QRS? And do I have a QRS after every P? Yes, I do. Do I have any unexpected pauses or drop beats? No, we do not. So this is sinus bradycardia. You can also see this is lead 2, and so my P wave is upright throughout. And so I'm fairly confident that this is sinus bradycardia. That is the name of my rhythm. Okay. We'll take a look at this one. So again, determining rate, this is lead 2. So I would expect to find a P wave either flat or upright in lead 2. So my rhythm is regular. If I were to measure between my R to R intervals, they're the same. And then my QRS complexes are clearly not prolonged. They are less than 3 small boxes or less than 120 milliseconds. So then I need to look for atrial activity. Do I see discrete P waves? No, I do not see any discrete P waves whatsoever. So I don't have a P before every QRS and a QRS after every P because I have no P waves whatsoever. I don't see any kind of deflections in the baseline aside from the QRS complex and the T wave. And so I cannot find any atrial activity at all in this situation. My rate, if I were going to try to determine rate, I'm going to use this QRS complex because it's right on that bold line. 300, 150, 100, 75, 60, 50. So this is a little bit less than 50 beats per minute. And so if I've got a narrow QRS complex, regular rhythm, bradycardic, but no discrete P waves, then I likely have a junctional rhythm, meaning that it is being generated around the AV nodal junction. In a junctional rhythm, P waves could in fact be there. They might be immediately before, so you have a very shortened PR interval. They could be after, so it could be a retrograde P wave, or it could very well be buried in the QRS. The atria do still contract with a junctional rhythm, and they do still contract before the ventricles, but now it's by retrograde conduction. As we look at this EKG, you probably have already recognized that this is classic atrial fibrillation, the appearance of classic atrial fibrillation. But let's apply our rhythm analysis to it. So the slide is asking us to first determine rate. Well, we don't have a full 12-lead ECG here, but if we were to do that, this is an irregularly irregular rhythm, so we would have to count QRS complexes over the course of the full 10 seconds of the ECG, and then multiply that by 6, which would then give us a rate of about 110 beats per minute with this tracing. So we know that our rhythm is irregularly irregular. My QRS complexes are clearly normal. They are not prolonged. They're less than 120 milliseconds. And so as I move on to my atrial analysis, can I identify any clear discrete P waves? No, I can't. I can probably tease out some T waves just after the QRS complexes. So if I were trying to tease out T waves, there's one here and here and here and here. But otherwise, that baseline activity is chaotic. It is bouncing around all over the place, and there are no true discrete P waves. So I have a narrow complex, irregularly irregular rhythm with chaotic atrial activity with a heart rate of about 110 beats per minute. And so this is clearly atrial fibrillation. So here's another example of a lead 2 telemetry strip. And in this situation, again, I'm going to try and determine rate. Well, my rhythm definitely looks regular. If I were to march out the R to R intervals across this entire strip, they would be pretty similar across the entire thing. So I have a regular rhythm, and my QRS complexes appear to be normal and not prolonged. So I have a narrow complex rhythm that is regular. And so if I'm going to try and determine rate first, I'm going to find the QRS complex that is closest to the big box marking, and then use the rule of 300 to determine. So 300, 150, 100. And so it is somewhere between 75 and 100 beats per minute. So I'm going to estimate around 80 beats per minute. And as I said, the rhythm is regular. I have a narrow complex QRS complex. And then if I'm looking for discrete P waves, well, the baseline clearly doesn't look as I would normally expect it to look. So there's no discrete P wave, QRS, and T. But I do have atrial activity because that baseline is definitely bouncing back and forth in a fairly patterned way. And so this is kind of that classic sawtooth pattern, which you have probably already recognized and know that this is atrial flutter. So I can't identify any true discrete P waves here, but I do have organized atrial activity happening on the baseline because there is a pattern to that atrial activity. So that is what is meant by organized atrial activity. And so in this situation, this is atrial flutter. So as a reminder, atrial flutter is a self-perpetuating reentrant loop in the atria. It's basically this wave of electrical activity that is moving circularly through the atria, and that's what's causing that sawtooth pattern, typically that's seen best in lead 2. That rate of that atrial wave is about 300 beats per minute, and the ventricular rate in this example is about 75, 80 beats per minute. And so if we know that the atrial rate is 300 beats per minute, and the ventricular rate is 75 beats per minute, so we know that for every loop that atrial wave takes, or every 4 loops that atrial wave takes, you get 1 conduction through the AV node. So this is 4-to-1 conduction. All right, let's take a look at this one. So we're going to determine the rate. So first thing that I notice is that my rhythm is regular, so I can use the rule of 300. I'm going to try and find a QRS complex that lands right on the large big box border. So here's one right here, 300. The next one is somewhere between 300 and 150. So my ventricular rate is around 200 beats per minute. My QRS complexes are prolonged. This is clear that they are quite big. So my QRS interval is prolonged. And so I know that I either have a conduction delay or I have a ventricular rhythm. So I'm going to be looking for atrial activity. Can I find any discrete P waves in this strip? No, I cannot. I do not see any discrete P waves whatsoever. I don't see any obvious atrial activity whatsoever in this one. And so then I would move on to my ventricular analysis, and I know I have a regular wide complex tachycardia running about 150 to 200 beats per minute. So this is ventricular tachycardia. And you may very well have recognized it immediately, but this is, it's reasonable to go through that systematic method and apply that when you're trying to determine a rhythm. So this is a wide QRS complex VTAC. If there are P waves, they're not associated with the QRS. And so you may see some examples of that. You may see retrograde P waves, meaning that they're after the QRS complex. If we were to take a look at this one, again, it's more pattern recognition, trying to determine rate and rhythm. Well, if I'm looking for the rate, I'm looking for discrete QRS complexes, which I do not see any QRS complexes whatsoever. I don't see any discrete P waves either. What we have is ventricular fibrillation. So no obvious P waves or QRS complexes. So there's no way to determine rate, and the rhythm is ventricular fibrillation. Okay, so that's the end of this section of the workshop. So next steps for you, make sure you review the steps of determining rhythm. Is the rhythm regular or irregular? Are the QRS complexes normal or prolonged? Is the atrial rhythm sinus? Are there any unexpected pauses or premature QRS complexes that you may need to identify? If the underlying rhythm is not sinus, what type of atrial activity is taking place? And if you can't find any atrial activity, then you need to think about what are the ventricles doing. Review those steps and then practice rhythm analysis on some ECGs. And then when you're ready, move on to part 3 of the workshop. See you there.